Hi everyone, and welcome to our last week on proteins. Next week we're going to talk about the interrelation of the macronutrients and metabolism, and we'll do a little bit on sport and macronutrient metabolism. But today we're going to finish up our protein section. So we're going to focus on proteins and their relationship with health. In this first section, our learning objectives are to explain the role of protein in different scientific fields, understand the role of protein in allergies and bone health, and explain how diet can impact mood and depression. So the goal of this first part, when we're talking about how protein is impacted in other scientific fields, is just to highlight the fact that as nutrition professionals, we're going to be interacting in interdisciplinary teams. And these are for the topic of protein, these are some of the areas where we would have some overlap, and the nutrition professional would need to give input to these specific fields. So the first field is sports physiology, and we see in the literature that for untrained individuals, there's really no likely impact of protein supplementation on lean mass and strength during training. However, as an individual becomes more trained, protein supplementation could be beneficial in that it could promote muscle growth and muscle strength. Now, protein supplementation could accelerate gains in both aerobic and anaerobic power. Now, some supplements that have been demonstrated efficacy in these processes are beta-alanine and creatine, and both of these supplements could suppress fatigue. So in the body, creatine is converted to phosphocreatine, which serves as a storage reservoir for regenerating ATP. So we can see why it would suppress fatigue. So you may think creatine, that's not an amino acid that we've read about, but creatine is related to protein because it's a nitrogen-containing chemical that's an essential part of the energy release system of muscles, and we find it in protein sources like meat. Well, we find it really only in meat. And it really helps transport extra energy to the muscle and allow muscle proteins to continue contracting. The next area where we find that the essentiality of proteins is in virology and immunology. And we've touched on this a little bit in the previous courses. So we know that proteins are important viruses, and they are important as integral aspects of the immune system. So when our body encounters an antigen, we are able to produce a protein, which is an antibody that's going to signal for the destruction of this foreign antigen. So viruses are composed of proteins, but they are kind of the negative aspect really of proteins when we're talking about virology and immunology, because we really know of no viruses that are actually beneficial to humans. Now, protein is also an integral part of these fields because we know that in individuals who are deficient of protein, this also decreases their immune function because immune cells, in order to be synthesized in adequate amounts and to function adequately, need to have access to the amino acids that compose them. Okay, next is microbiologists. So the reason that this is protein is dietary protein is important in this field is because we have a shortage of protein in the world's supply. So we really have more than enough food in some ways. How it's distributed is kind of a problem. But really one fear as our population grows and grows is that there's just not enough protein to supply all these people. So one solution has been to kind of farm these certain types of microbes that can produce a really impressive amount of quantity for their size. So yeast, for example, is a microbe that can form a nutritious food, and it can be grown on molasses. It's a waste product of sugar refining, and it can also be grown even on petroleum. And this yeast is a really good source of protein for its weight. Algae is an aquatic plant that includes seaweed, and these could have high yields of protein. And spirulina grows on salty lakes. So why aren't we utilizing these more as protein sources? That it's, look, if you look at this middle picture of the spirulina, then, or I guess it's the algae maybe in the middle. Either way, people really aren't ready to accept these types of proteins, and we really are trying to still develop the technology that's needed to produce and harvest sufficient quantities of these proteins. So to be continued. One big area where protein is, and especially dietary protein, is a big issue is in allergies. And this is probably no surprise to any of us. So allergic reaction recurs when an intact protein is absorbed through the GI tract, and then our body sees it as foreign and labels it as an antigen, and we make antibodies for that antigen. And therefore, when we're exposed to that particular protein again, our body kind of overreacts in this kind of inflammatory process. So why does this happen? Aren't we supposed to break down all of our proteins before they get into the GI tract? Well, some proteins can escape digestion, either because of their size or their properties, or because of a compromised epithelial lining in the digestive tract, and then they can be absorbed straight into the blood. So antibodies are created to ensure that no intact proteins or large peptides enter the blood, but the system can have faults. And this is specifically pertinent in infants. So I think we've talked about earlier in the class that infants just naturally have a leaky kind of GI tract where they don't have these tight junctions in their epithelial lining. And that's for a purpose, because the infant gut is designed to absorb these intact antibodies that the infant is receiving from the mother's milk. However, this can have negative consequences if these kind of different proteins that could be antigens are introduced. So I did it a little bit different just to kind of put your discussion questions in the context of the lecture. Here are your discussion questions. So after reading your article about allergies, discuss the different types of food allergies. So those that are IgE mediated, non-IgE mediated, or mixed. And then here's a case study. So a client comes into your office and feels she has a gluten allergy due to diarrhea, gas, and dermatitis when she consumes gluten. But she had an allergy test and she tested negative. So the physician assumed this was kind of all in her head and she was just kind of jumping on the gluten-free bandwagon. So how could you counsel this client? Okay, the next topic I want to move on to is osteoporosis in bone health. So we do see, this has kind of been a contentious topic in the past. And the reason for this is that in the beginning, we saw that increased dietary protein intake led to increased urinary calcium excretion. So we assumed that a high protein diet would cause bone reabsorption. And the reason, the kind of hypothesized mechanism behind this was that especially animal proteins have these sulfur compounds that can be acidic, and then our bone in response would release, would break down, release bicarbonate in order to neutralize the acid. However, we see now that it doesn't work exactly like we thought. So yes, increased protein does increase bone resorption, but it also increases our growth factors, which could lead to increased bone anabolism, or bone growth of osteocytes. So yes, we do have increased turnover when we are have higher protein intake, but actually this is good. We find that this is a good thing for bone health, because when we have an adequate protein intake, we have a better bone density and reduced fracture risk. And that brings us to our second article questions. So again, just kind of to place it in the context of the lecture. So after reading the Tang article about weight loss and high protein diets, discuss the physiological impact of protein on bone health. And then the case study is that you have a client who's postmenopausal, overweight female, and she wants to decrease the amounts of carb and fat in her diet, but she's had a family history of osteoporosis, and she's worried that too much protein will exacerbate that condition or increase her risk. So how would you counsel her? Okay, protein can also have an impact for renal stones. So we see that individuals who have a combination of a low calcium diet and high animal protein diet, this does ultimately cause a negative calcium balance. So high animal protein diet is actually a risk factor for calcium stones. And this is because, but this may vary by sex or BMI. So yes, we talked about protein does cause increased calcium excretion, and this might not be a problem for our bones if we're going to have, if we are going to be able to build up our bone again, but we still have this increased calcium in our systems that our kidneys have to filter. So this could lead to higher risk of calcium stones. However, we see that association, but introduction of a low protein diet has not demonstrated efficacy in decreasing risk of kidney stones unless we really supplement high with calcium and decrease sodium. Okay, so last is the relationship between proteins and stress-related mood deterioration or depression. So you can see in this graphic here that we have tryptophan, which is our amino acid, and that is ultimately converted into serotonin. And, you know, I'm not sure how much exposure we've had to these, this type of area, but basically serotonin is kind of what we think of as our kind of happy neurotransmitter. So it makes us feel really good. Okay, so plasma amino acids, so we would tend to think that maybe the more tryptophan that we introduced into our diet, the more serotonin we could produce, but that's not necessarily the case. And the reason for this is that there's other amino acids that have a similar structure to tryptophan, and they compete for incorporation into the brain by incorporation through the blood-brain barrier so that they can go into the brain. So some of these amino acids are tyrosine, phenyl, and phenylalanine, and these are precursors for catecholamines, dopamine, norepinephrine, and epinephrine. So they can be converted into very different kinds of substances than serotonin. So some of these amino acids, we call them all these large neutral amino acids. So the ones I mentioned, and then we also have our branch chain amino acids, leucine, isoleucine, and valine. And these compete for attachment at the same transport carrier located on the blood-brain barrier for uptake into the brain. So the effect of manipulating one of these amino acids, so for example, the tryptophan, on brain biochemistry is not going to necessarily depend on our concentration of tryptophan per se, but really on the ratio of plasma tryptophan to the sum of these other competing amino acids. So food intake can influence the synthesis and function of different neurotransmitters in the brain by changing the concentrations of these different amino acids. So again, it's not necessarily how much tryptophan we're consuming, but how much we're consuming in relation to these other competing amino acids. So protein intake actually, surprisingly, decreases serotonin. And this is because proteins actually have relatively low concentrations of tryptophan, but it has a lot of other amino acids, so there's lots of competition with the amino acids. So again, in this situation, plasma tryptophan would not necessarily reflect serotonin production. However, we do see, interestingly, that carb intake does increase serotonin. So the reason is because carb-rich foods are found to increase plasma tryptophan ratio because there's really not that much, you're not introducing a lot of these other competing amino acids, so it gives kind of an advantage to competition for access to the brain, which will increase brain tryptophan. So this increase in brain tryptophan is produced by carb-induced elevation of glucose and insulin, which, with the exception of tryptophan, causes these competing amino acids to be taken into the skeletal muscle for conversion into protein. So basically, I'm going to eat carb. It's going to increase my insulin. It'll increase my glucose, which will increase my insulin, which will cause me to take these competing amino acids into my muscles, but it frees up tryptophan. Tryptophan is not taken into the muscles. So then we have a higher tryptophan ratio, more incorporation into the brain, higher rise in serotonin. So we do see that we can impact serotonin, but that manipulating the diet really just it might have a modest effect on increasing mood by increasing serotonin in individuals who are at risk of these mood disorders or depression, but it really doesn't have that much of an impact on healthy individuals. And here's just a little bit of a graphic here. So we see our plasma tryptophan to large neutral amino acid ratio either increases or decreases the incorporation of tryptophan into the brain by going through the blood-brain barrier. And proteins increase plasma neutral amino acids and increase tryptophan. So we don't really get much of an advantage in this tryptophan ratio, but with carbohydrates, it has a negative impact on the plasma concentrations of these competing amino acids, but still increases availability of the tryptophan. Okay, so here are our practice questions. Here are our practice questions for this section, and let's move on to the next section. So this section is about metabolic disorders that are involved in protein metabolism. So our learning objectives for this section are to list and discuss metabolic disorders of proteins, and they're listed here, and we're going to talk about them. Explain homocysteine and its relationship with heart disease, and explain differences in protein, energy, malnutrition, including marasmus and kwashiorkor. So I know we've talked about these last couple conditions in P and before, but of course they're very relevant when we're talking about protein. So our first metabolic disorder that we're going to examine is a disorder of phenylalanine and tyrosine. And let me see if I can pronounce it. Alkaptonuria. Sorry, that's a really hard one. But basically, this metabolic disorder is a deficiency of the homogenistic acid oxidase. Okay, this can also be called homogenisate dioxygenase. I've seen it both ways. And basically, it prevents the conversion. So here we're starting with phenylalanine and tyrosine from the diet. And then we kind of have this downward metabolism, which is going to end in fumarate and acetoacetate. But in this pathway, when someone has this metabolic disorder and they're missing this enzyme, then we're going to have an accumulation of this substrate, homogenistic acid, or also we could call it homogenisate. So basically, the body builds up so much of this homogenisate that it's unable to utilize it. Okay, so it accumulates in the body, and then this is excreted in the urine. And the reason for this, it's this excretion in the urine that gives this disease its kind of characteristic dark brown or black urine. And what's happening is that this compound, this homogenisate, is oxidized when it reaches the air and turns dark brown or black at that point. So the diagnosis of this metabolic disorder does not depend solely on the darkening of urine, because dark urine could be a result of other conditions such as bile or myoglobin or hemoglobin in the urine. Okay, so this metabolic disorder is benign in childhood, but in the third or fourth decade of life, it may be manifested by ochronosis, arthritis, and changes in pigmentation. So this ochronosis is basically a bluish-gray discoloration, and it can be in multiple areas of the body. So often it'll start in the external ear and move to the nasal cartilage and area under your nose and above your mouth, your maxillae. And then you also could have discoloration in your small joints, especially over tendons. And then other areas where we might see this discoloration would be in the genital area because this homogeneity is excreted in perspiration. So here are some pictures of this ochronosis, and you can see this kind of bluish discoloration. And once this is once it's established, we really don't know of any effective treatment as far as I'm concerned. But once we have the development of this ochronostic arthritis, it is chronic and progressive and can attack the joints and spine. So in this condition, joints and spine can gradually become rigid and produce kind of the stooping posture. However, if a person doesn't develop this ochronosis or arthritis, then this alkaptonuria may go undiagnosed. Okay, so let's move on to maple syrup urine disease. So this is also known as branched chain ketoacidemia, and this is also caused by an enzymatic defect in metabolism, but for this condition, it's of the branched chain amino acids leucine, isoleucine, and valine. And this condition is present right from the beginning of life. So because we're not able to metabolize the branched chain amino acids, these build up along with their keto derivatives in the spinal fluid plasma. So levels of these keto derivatives in the spinal fluid plasma could be up to 7 to 14 times higher than in normal individuals without this condition. So the presence of a molecule called allo-isoleucine, which is a derivative of isoleucine, is diagnostic, since we don't know of any other condition in which this molecule is present. And maple syrup urine disease gets its name from the characteristic color and odor of urine, skin, and perspiration, which is sweet and caramel-like, malty, or smelling like maple syrup. And you can see this sample of this urine sample of a person who had maple syrup urine disease. So this is also a metabolic disorder that is present right from the beginning of life and is characterized by irritability, refusal to feed, lack of weight gain, loss of reflexes, and jerky, that should say respiration. Fix that real quick. Okay. However, a rare infant could survive, but usually with neurological or disorder or a mental retardation, even though we don't really know the cause of this mental retardation in this condition. So if the infant does survive after the first few days of life, then there are alternating periods of hyper or hypotonicity in the muscles, convulsions, seizures, and even respiratory disturbances that are common and often fatal. So, children can survive this if they are treated. However, patients who are treated are still susceptible to secondary infections, such as ear infections, throat infections, bronchopneumonia. So we are, again, if this can be diagnosed in early life and we can treat it, then we can treat it with dietary management. So how we would treat this is because we have problems in this condition, metabolizing branched chain amino acids, then we would implement a branched chain amino acid free diet. However, we do need to keep in mind that we would do this until the plasma levels return to a normal level. However, it's good to keep in mind that isoleucine and valine do return to normal levels before leucine, and so supplementation with solutions of these two amino acids is necessary in order to prevent a negative nitrogen balance of amino acid deficiency, which could result in further elevations of these amino acid levels. So if untreated, this disease is fatal by 20 days of life, but if we catch it early, we can treat it. Okay, next I want to move on to hereditary tyrosinemia. This is an autosomal recessive condition, so both parents have to be carriers, and if they are both carriers, then the child has a 1 in 4 chance of getting it. This condition, this hereditary tyrosinemia, is most prevalent in French populations and their descendants living in North America and the Scandinavias. So there are 2 types of hereditary tyrosinemia. So type 1 they both are impaired tyrosine metabolism, but type 1 is a deficiency of the fumarate acetoacetate hydrolase enzyme. So here we have our little graphic. This was from before. So this was our L-captonuria, and then here we have lower down in the tyrosine metabolism, the enzyme that I just mentioned, and if this is lacking, then we have a buildup of this fumarate acetoacetic acid. Yes, but the mechanism is pretty complex. Okay, so in the early stages of this disease, we note signs of vomiting, diarrhea, failure to thrive, and abdominal distension. And moving forward, symptoms may include, or signs or symptoms may include hepatosplenomegaly, ascites, edema, and I'll just let you read through all of these other signs and symptoms, but basically it has wide-ranging effects. So we do need to distinguish this type of tyrosinemia from transit neonatal tyrosinemia, which is due to basically an immaturity of the enzyme system. So we see this in premature infants and some term infants who are fed a really high protein diet but inadequate ascorbic acid. So, but this transit neonatal tyrosinemia responds to reduction in protein and ascorbic acid supplementation. So if an infant didn't respond to these this treatment, then we would then they may have hereditary tyrosinemia. Okay, and then we also have a type 2 of hereditary tyrosinemia, which is less frequent. It appears to result in these keratitic skin lesions. So you can see these on these hands here. And another outcome is mental retardation, though again, we really don't know the etiology of why this occurs. So tyrosine-restricted diets do actually give dramatic relief to the skin lesions and cerebral function, but it's really just not enough to restore a normal metabolic phenotype and prevent the hepatic deterioration that accompanies this condition. So you can have a treatment of a liver transplant, but that's a major surgery and there's a lot of complications, so that would have to be very carefully considered. And there is prenatal diagnosis available through testing of the amniotic fluid in the 3rd trimester. Just one second. I just need to pause this for 1 sec. Okay. Sorry about that. Okay. So next is kind of maybe a more common error of protein metabolism that we've heard of, which is the phenylketonuria, or PKU. So this is a congenital impairment of phenylalanine metabolism, in which there's a deficiency of the enzyme phenylalanine hydroxylase. Therefore, we're unable to convert phenylalanine to tyrosine in the liver, and then phenylalanine accumulates in the liver and blood. So phenylalanine, high phenylalanine concentrations in the kidneys then are converted to their ketone body form, which is phenylpyruvic acid. And this ketone body can actually cause brain damage. So this was actually one of the first metabolic disease that was associated with mental illness, and one of the most widely applied genetic tests. So here's, you can't really see it super well, but here's this little heel prick of an infant. So in hospitals, or I guess outside the hospital too, but one of the first things that we do is do this metabolic screening for infants, and one of the primary conditions that we're testing for is PKU. And one of the reasons of this is because PKU is kind of known as this hidden disease, because the infant in the beginning appears to be completely normal, and their test for urinary phenylpyruvic acid, this ketone body, could be negative in the first few days. So therefore, we actually have to test the blood to note these levels of phenylalanine in these ketone bodies in the blood in order to diagnose this. So one reason why we really need to diagnose this so early is because it's really crucial that we initiate dietary management in order to prevent these cognitive issues that we see with PKU. So management of the diet requires just incorporating enough phenylalanine to be necessary for growth and maintain serum phenylalanine within acceptable limits. So we don't want to give, we want to give very little phenylalanine, just enough for growth, and otherwise, but be sure otherwise to supply nutrients and energy to support growth and normal intellectual development. And this is tough to do because most food proteins, or all naturally occurring food proteins, actually have actually do contain phenylalanine. So this kind of dietary management can be really challenging. And here we just kind of have this little graphic. We have our dietary and tissue protein, and then we have in PKU, we have a problem with our enzyme here, phenylalanine hydroxylase, which prevents it to being converted to tyrosine. And then the consequence is that phenylalanine is converted into these ketone bodies. Okay, and then here's a graphic that kind of pulls together what we've been talking about. So here we have phenylalanine and its conversion to tyrosine, and we can see that the deficiency of phenylalanine hydroxylase is what results in PKU. Then we can see that the error from the transition of tyrosine to, again, hydroxyphenylpyruvate is where we have this tyrosinemia 2. We didn't talk about these, but another error of metabolism is tyrosinemia 3. This one is the deficiency in homogeneous state oxidase results in alkaptonuria. And finally, in this last stage here, we have the error that results in tyrosinemia 1. Okay, now I kind of want to switch gears a little bit and talk about homocysteine. Okay, so homocysteine is a sulfur-containing amino acid that's formed during methionine metabolism. And homocysteine is metabolized by one of two pathways. So it can be metabolized in the remethylation process or the transsulfuration process. So in the remethylation cycle, homocysteine is salvaged by the acquisition of a methyl group in a reaction catalyzed by methionine synthase. So here we have our sorry, I wish this was a little bit more clear. Here we have our homocysteine here, and here we have methionine synthetase here in order to transfer a methyl group. So in this process, vitamin B12 is a necessary cofactor, and N5, here we go, N5 methyl tetrahydrofolate, or methyl THF as it's shown here, is the methyl donor in this reaction to donate the methyl group to the homocysteine in order so that it can be converted to methionine. And the N5N10 methyl tetrahydrofolate here, reductase functions as a catalyst in the remethylation process. Okay, so here is our remethylation process here, where homocysteine accepts a methyl group and is converted to methionine. Now, in the transsulfuration reaction, which is noted down here, homocysteine condenses with serine to form, let's see if I can pronounce it, cystathione in a reaction that's catalyzed by a B6 dependent enzyme, cystathione beta synthase. And cystathione is subsequently hydrolyzed to form cysteine here, and which may in turn be incorporated into glutathione or further metabolized to sulfate, which will be excreted in the urine. So we've kind of set up, we realize that and I'll talk more about why we don't want homocysteine in high levels in our systems. We don't want homocysteine urea, or emia or urea, basically. So we can convert it through a couple of these processes, but these processes both require cofactors such as B12, B6, and then folate. Okay, so if we have a deficiency in any of these cofactors, then it can lead to hyperhomocysteinemia, or a buildup of homocysteine in the blood. So diets that contain abundant methionine actually require sufficient B6, B12, and folic acid to prevent high blood homocysteine. So this makes sense. So I'm just going to flip back to the last one real quick. So we see that not only can homocysteine be converted to methionine, but methionine can be converted to homocysteine. So then we need to supply these cofactors that can help to convert homocysteine again. Okay, and why is this a problem? Well, we know that vascular disease is directly correlated with homocysteine level, even in the normal range. So of levels of over 14 micromoles per liter, we know there's increased risk of coronary heart disease. But even within the normal range, our risk increases with our level of homocysteine. So symptoms of homocysteinemia affect many systems in our body, including our nervous, cardiovascular, musculoskeletal, and hepatic systems. And mental retardation is associated with homocysteinemia, although this is not in all cases. So some adults who have homocysteinemia also do have normal intelligence. And we have multiple causes of homocysteinemia besides these nutrient deficiencies, and these are listed here. So, like other sulfhydryl compounds, homocysteine increases formation of oxycholesterols and other oxidized lipids and proteins during the modification of LDL in our blood vessels. So there's kind of a possible interaction between homocysteine and lipoproteins and cholesterol that involves an altered oxidation process within the cells of developing atherosclerotic plaques. So basically, the presence of homocysteine in our blood vessels is going to promote oxidation of these other nutrients, so lipoprotein and cholesterol. And as we know, when we have oxidation of our of these lipoproteins, and also of the cells that kind of are recruited to handle these lipoproteins, our macrophages, then we have development of our atherosclerotic plaques. And I do have a little video coming up that'll hopefully demonstrate that better. So one form of homocysteine is thiolactone, and this form we know causes elevation in serum triglycerides, LDL, and cholesterol. Okay, so here's a reminder of how atherosclerosis works.
This condition is a process in which deposits of fatty material, called plaque, build up inside the walls of arteries, reducing or completely blocking blood flow. Although the exact causes of atherosclerosis are not clear, many scientists think it begins with damage to the inner wall of an artery, called the endothelium. Substances traveling in the blood, such as cholesterol, fats, and cellular waste products, accumulate inside the damaged area of the arterial wall. Chemical reactions occurring within the buildup of material cause cholesterol molecules to oxidize. This initiates an inflammatory response in which the endothelial cells at the damaged site release chemicals that signal a call for help. In response, monocytes from the bloodstream travel to the damaged site. Stimulation from oxidized cholesterol converts the monocytes into macrophages. The macrophages eat and digest the cholesterol molecules. As a result of this process, the macrophages change into foam cells, which accumulate to form plaque. As the plaque increases in size, the arterial wall thickens and hardens. At the same time, smooth muscle cells within the arterial wall begin to multiply. Most of the smooth muscle cells move to the surface of the plaque. These cells contribute to the formation of a firm, fibrous cap covering the plaque. Eventually, the passageway through the artery narrows enough to reduce blood flow and the amount of oxygen received by the organs it supplies. Over time, the cap may erode and break open, releasing plaque into the bloodstream. The plaque can flow downstream and contribute to the formation of a blood clot, which can stop blood flow. As a result, limited blood supply is available to the areas surrounding the partially blocked artery, degrading and potentially killing the neighboring tissue.
Okay, so we can see that if homocysteine basically results in increased cholesterol oxidation, then that's going to have a negative impact on the development of our atherosclerotic plaque. So we know that the thiolactone form of homocysteine reacts with LDL to produce these aggregated, dense form of lipoproteins that are taken up by the macrophages to form foam cells. So LDL that contains homocysteine bond by a peptide bond with the apolipoprotein B protein is present in patients who have hypocholesterolemia. And what this suggests is that aggregates that carry homocysteine in the bloodstream to foam cells of early plaque, where the amino acid modifies the oxidative and synthetic processes of the artery cell walls, this all promotes atherosclerosis. So basically, the higher the homocysteine, the higher the oxidation of these cholesterol-containing molecules, the more development of atherosclerosis. Okay, so we saw that we have two pathways by which we can decrease our homocysteine levels by converting them to other substances. However, there could be other factors that could decrease our ability to convert this homocysteine to these less damaging molecules. So these could be these factors could be dietary, genetic, toxic, or hormonal, but basically they have the same end result, which is overproduction or overaccumulation of homocysteine from methionine. So we can treat this by introducing nutrients such as vitamin B12 and folic acid that will activate remethylation, or vitamin B6 that will aid us in transsulfuration. That. Okay, so when LDLs are oxidized and form these foam cells, then they release lipids and cholesterol into fibrolipid plaques. Now, homocysteine also facilitates smooth muscle hyperplasia and fibrosis. So from the video, you saw that that was kind of the second part of it, where we basically we have kind of this these oxidized foam cells that are forming this plaque, and then in response, our body what should I say, transports our smooth muscle cells to form this fibrous cap to decrease the negative impact of these plaques in our arteries. But, you know, this can be a problem if this fibrous cap starts to break. And the homocysteine actually does facilitate this hyperplasia and fibrosis of the smooth muscle cells. So overproduction of these ROSs causes intimal damage and oxidizes portions of glucosaminoglycans. They activate the elastase enzyme, and they incite thrombogenesis and increase calcium deposition in the arteries, which all contribute to the formation of atherosclerotic plaques. Now, one different mechanism is by which homocysteine causes damage is that it can be auto-oxidized to produce potent reactive oxygen species, and particularly hydrogen peroxide. And this process is implicated in the implicated for part of the toxicity for hypohomocystinemia, which causes damage to the endothelial lining and supports LDL oxidation. Okay, so let's move on to our last topic, which is protein energy malnutrition, and we're focusing on our two conditions, kwashiorkor and marasmus. So kwashiorkor is a diet that has maybe enough calories, but they're all from starch and sugar and deficient in protein and essential amino acids. And in contrast, marasmus is just complete deprivation. We don't have enough of anything, including protein. And then there's also intermediate forms that are termed marasmic kwashiorkor. So kwashiorkor is the less common of the two, and it's usually manifested as the intermediate marasmic kwashiorkor state. And really, the pathogenesis of this condition is not fully accepted by researchers, but it does tend to be confined to parts of the world where the staple foods are really high in sugar and carbohydrate, but deficient in protein. Marasmus, on the other hand, is kind of the predominant form of protein energy malnutrition that we see throughout most non-industrialized nations. And this condition can be associated with early discontinuation of breastfeeding, which results in consequent infections such as infantile gastroenteritis, and this puts the infant at even higher risk of protein energy malnutrition. And I think we've talked about in the past lectures that this can often happen when a mom will have a second baby and therefore breastfeed that baby, but maybe the first one wasn't still needed the nutrition and doesn't have another way of getting it. Okay, kwashiorkor. So the decreased protein synthesis, even in the presence of increased carb, does decrease visceral protein synthesis. And this includes decreased production of albumin in the blood. And this, in turn, the consequences are edema and impaired lipoprotein synthesis, and which produces a fatty liver. So if we're not able to basically export the fat and cholesterol from the liver, we have development of a fatty liver. And this kwashiorkor can actually result in the hospital for patients that are, such as for patients who are fed glucose for many days, because maybe they had a slow recovery or from a surgery that prevented normal food consumption. So they're just kind of kept on this glucose drip for longer than they had anticipated. But there's no protein. So that can happen in that situation. So in marasmus, we have, again, low calories from all sources. And so we said it could be from early weaning due to a younger sibling being born, or it could be if the mom is formula feeding, maybe if they're in a situation where poverty is an issue, then common fear is that formula will be over diluted so that it will last longer, and therefore there can be malnutrition. Okay, so in both of these conditions, children experience diarrhea, infections, and multiple nutrient deficiencies. So, however, we do have some differences between the conditions. Now, separating these two conditions into two completely separate classifications really oversimplifies the condition, but these are kind of the extremes of marasmus and kwashiorkor, and in the extremes, they do have some marked differences. So we can see here just what we've talked about. In marasmus, it's complete deficiency, whereas in kwashiorkor, it's really inadequate protein intake. Marasmus is slow developing, where kwashiorkor can be acute. Marasmus is severe weight loss, where kwashiorkor, you could have some weight loss because it's not all nutrients that are being deprived. In marasmus, we have severe wasting of fat and muscle. In kwashiorkor, we do have muscle wasting, but we can have retention of some body fat because the child is getting some nutrients. Marasmus is, just like we would assume with severe wasting, much more severe growth retardation compared to kwashiorkor, though kwashiorkor does include growth retardation. Marasmus does not include edema, whereas kwashiorkor does, and if we see kind of you see the commercials for these kids who are malnourished. You see they have these kind of bloated bellies, and that's part of it. That's the edema. In kwashiorkor, we also have an enlarged fatty liver. In both, we may have apathy, but in marasmus, we could have anxiety as well. In marasmus, the child could have a possible appetite or experience hunger, whereas in kwashiorkor, anorexia or lack of appetite may develop. And then we also have alterations to hair and skin. Okay, so we do have differential diagnosis depending on secondary to growth failure due to malabsorption, congenital defects, or deprivation. And it is important to note that the skin changes in kwashiorkor are different from those that we note in pellagra, which are occur in areas that are exposed to light and are more symmetrical. Okay, so for treatment, it's pretty much the same. So for both conditions. So we first want to correct dehydration and replete nutrient deficiencies. We want to treat the low body temperature and treat the infection. So these are the very most severe symptoms that we just want to handle right off the get-go. And then as time moves on, we can begin to kind of gain back these losses by introducing mixed foods and increasing calories and protein per calorie of body weight. But as we saw for some of the kids, there may be actually no appetite or anorexia. And some of the children may be so weak that we have to actually feed by hand. And of course, a multivitamin is important in this stage as well. So after about 3 weeks, children typically do have improved appetite, but it does take a really long time for catch-up growth to be completed. And of course, as with any condition, we need to look at the social aspect. So if a family is experiencing poverty or social issues, a mother a mother particularly, but also, you know, the family as well needs to be supported to prevent recurrence, basically. So mortality for these conditions ranges from 15 to 40%. We do need to be careful about how we refeed these children because we can cause an electrolyte imbalance, which can actually cause death. And other conditions in the first days of treatment could be mortality in the first days of treatment could be from infection or hypothermia or heart failure. And heart failure could be related to electrolyte imbalance. Children who are malnourished may experience mental impairment, but this is dependent on the duration of malnutrition and the severity as well as the age of onset. Keys to recognizing mild or moderate protein energy malnutrition are implementing maternal and child health clinics. So these can have really low tech methods of trying to assess children for these conditions. So all we really need is a way to weigh the child in a growth chart and a way to measure mid-upper arm circumference, as this is a really accurate measure of malnutrition in children. Okay, so here are our practice questions 2, and we will have our last lecture next week.